Alright, so in this lecture we're going to talk about the anatomy of the hip joint. The osteology of the hip is mainly comprised of the acetabulum and the femur, which we'll talk about on the next slide. So the acetabulum, it's a cup-shaped bony structure formed by the fusion of three bones: the ilium here, the pubis here, and then the ischium. And this is a great picture that shows you how they, along this three-point line here, how they all fuse together to form the acetabulum, and it's the socket portion of the ball and socket hip joint. So this is what receives the head of the femur. One thing to note, so this is an anterior view of the bony pelvis, is the outer rim of the acetabulum is actually covered with this fibrocartilage labrum. Just like in the shoulder joint, how the glenohumeral joint has that labrum, same concept here. It has this fibrocartilaginous ring, and it, again, just like the shoulder, it deepens the articular socket and helps stabilize the hip joint. One thing to note is it does not completely encircle the rim of the acetabulum here and here, and what that does is it leaves an acetabular notch inferiorly. This is bridged by what's labeled here as the transverse acetabular ligament, which you can see here stretching across, and it also forms a foramen for vessels and nerves to travel through. The femur, again, like we've said, the head forms the ball of this ball and socket joint, articulates with the acetabulum. Both the femoral head and the acetabulum are covered with articular cartilage, and the femur also provides insertion points for many of the muscles that move the hip joint. Concept we want to explain here real briefly is femoral neck angle, and so this is formed between the longitudinal axes of the shaft and the neck of the femur. So here's the shaft, here's the neck, it's this angle right here. Normally in newborns that angle is 150 degrees, but in adults it ranges from 120 to 135. Changes in this angle can result from a variety of pathologies such as hip dislocation or changes to the trabecular pattern within the bone. So Coxa Valga is when the angle is greater than 135 degrees, so that's this part right here. So the angle here they show is 140, which is greater than 135, and that results in a more upward straight femoral neck, as you can see here, versus the normal femoral neck here. Coxa Valga is describing when the angle is less than 120 degrees, and so that results in a more horizontal femoral neck, and you can see that here. Here's the femoral neck, much more horizontal than the normal. Alright, so now we're going to talk about the hip joint capsule and some of the ligaments involved. So first, the fibrous joint capsule, the attachments. So proximally, it's the outer rim of the acetabulum, so you can see that here and here, and the transverse acetabular ligament, which would be down in here. Distally, it's the neck of the femur, so again, you can see that right here and then right here. And then anterior would be the intertrochanteric line and the base of the greater trochanter, so that would be nicely right here. Here's that intertrochanteric line that connects the greater trochanter with the lesser trochanter. It's labeled nicely here for us. Posteriorly, it'd be the intertrochanteric crest, so you can see that here traveling again from both greater to lesser trochanter. And then it's reinforced by the following ligaments, and these are three pretty important ligaments to know, especially for an anatomy exam. Iliofemoral ligament anteriorly, you can see that labeled here. Ischio-femoral ligament posteriorly, you can see that here. It's really this entire ligament here. And then the pubo-femoral ligament inferiorly, which is this nice little ligament shown right here. So first we'll talk about the iliofemoral ligament, and this arises from the anterior inferior iliac spine, and you can see that right here. So here's that bony prominence, and then also the acetabular rim, which would be here. Attaches distally to the intertrochanteric line of the femur. That would be this line right here, connecting greater trochanter to lesser trochanter, so it attaches along there. It has an inverted Y shape, and what they mean by that, so this would be the outline of it right here, like this. So it has kind of, you know, if you were to take the Y that's normally like this, and then you invert it like this, that corresponds to, you know, so this is the two arms of the Y there. So that's why they say an inverted Y shape. And then it prevents hyperextension and lateral rotation of the hip joint while standing. Ischio-femoral, so this is a posterior view, attaches to the body of the ischium and the greater trochanter of the femur. So again, here you see it wrapping around like this, and so it comes out from the body of the ischium here, and then it travels in here to attach to the greater trochanter, which would be in here, and it limits extension and medial rotation of the hip. Pubofemoral ligament, found in here. So again, we'll outline, this is the ischiofemoral ligament, like here with that Y shape. This ligament coming in here like this, so we'll draw it in with some blue here. This ligament is the pubofemoral ligament coming out this way and then attaching to the intertrochanteric line. So as you can see here, it travels under or deep to the ischiofemoral, and then it emerges out here to attach to the intertrochanteric line of the femur. It's triangular shaped, and then it limits extension and abduction of the hip joint. Ligamentum teres. So this attaches to the floor of the acetabular fossa, and you can see that here. This would be a lateral view of it. And the fovea capitis femoris on the femoral head. So as you can see here, it comes out from the floor of the acetabular fossa, and then it attaches to the head of the femur here. And within this ligament there's often an artery called the artery of the head of the femur, also known as the foveolar artery. And this originates from the acetabular branch of the posterior branch of the obturator artery. So you have the obturator artery traveling in here, and then you have the posterior branch, anterior branch. So then you have an acetabular branch that comes off like this, and that gives rise to this artery of the head of the femur. And actually in children, it provides a significant percentage of the blood supply to the femoral head. So muscle movements, very briefly here. This is a table we provided for you in your book, and it goes through each of the movements of the hip and which muscles are responsible for those movements. I'm not going to read through all of these to you. You can read them on your own in your book, but it's just to give you a nice clean list of each of the muscles involved for each action of the hip. So in case you get asked this on an anatomy exam, this is a way that can help you kind of organize the information. All right, so for the blood supply of the hip joint, the major artery supplying it is the medial circumflex femoral artery, and this is a branch off of the femoral, or sometimes the profunda femoris artery. This is similar to how in the upper extremity the brachial artery branches into the brachial and profunda brachii. It's the same kind of thing. So you have the femoral artery, which is an extension of the external iliac at the border of the inguinal ligament. So once that artery passes there, it turns into the femoral. And then the femoral artery gives rise to the profunda femoris artery. And off of one of those is the medial circumflex femoral artery, and that provides the majority of the blood supply to the femoral head and the hip joint. Damage to this artery can be very serious. It can result in ischemia and eventual osteonecrosis of the femoral head, which is where you have just complete death of the femoral head, and then at that point you would need to do surgery and replace it. Another important thing is that the medial circumflex femoral artery forms an anastomosis with branches of the superior and inferior gluteal arteries, and then you can also see that it has a nice ring around the femoral neck here by forming an anastomosis with the lateral circumflex femoral artery as well, similar to the circumflex humeral arteries around the head of the humerus. So the lateral circumflex femoral artery, again, just like the medial, it's a branch of the femoral or the profunda femoris artery. Now, the reason why it's not the major blood supply to the femoral head and hip joint is that it has to penetrate through the thick iliofemoral ligament. And just to remind you, this is the anterior view. Here's that thick anterior iliofemoral ligament. So that impedes the artery from becoming the major blood supply because it's got to make its way through that. We'll give you another nice here anterior view here. So here's the lateral actually coming off the profunda femoris artery here, and then it branches into some ascending and descending branches. The ascending branches form a vascular ring with branches of the medial femoral circumflex artery, so that's that ring of anastomosis or arterial ring around the base of the femoral neck, and then it also forms anastomoses with the branches of the superior gluteal artery as well. Some additional vessels, the artery of the head of the femur, we talked about this, goes through that ligamentum teres, and then you have superior and inferior gluteal arteries, which we've talked about. All right, so some clinical pearls relevant to the hip joint. So first, hip dislocation. It's in the name. It's where the femoral head dissociates from the acetabular cup. So almost kind of shown here in this diagram here, where it comes out of the cup like that. Mechanism of injury is typically high energy trauma, commonly in motor vehicle accidents. The dashboard injury, where you're sitting with your hips flexed and then your knees jam into the dashboard during an injury, and that's what could potentially cause this. These patients will present with acute hip pain, inability to bear weight on that side, and then often potentially physical deformity of the hip. Posterior dislocation of the hip, where the hip would come out like this, commonly presents with the thigh in the following position: adducted, flexed, and internally rotated. So adducted this way, flexed would be up this way, and then internally rotated, so in like this. And you actually might see this description in a question stem, so you want to be aware of this. Anytime when you see these, we lay out these positions of the hip in a particular injury or pathology, you want to pay attention to that, because this can actually help you give you the answer when you're reading this in a question stem for a board question. So it's often associated with injuries such as fractures of the head or the neck of the femur, and that makes sense. Complications, sciatic nerve injuries, obviously, because the sciatic nerve is traveling here, right behind it. Arterial injury, which could result in osteonecrosis. The way you diagnose this is X-ray. It's a structural injury. You'll very easily be able to see it. Treatment, you do emergent close reduction, which means, in the ER, you just pop it back into place, or you have to do surgical reduction, where you have to go in and surgically put it back in place. Osteoarthritis, a very, very, very common problem. This is arthritis that occurs with age, and where it's your usual wear and tear on the joints. And what happens is you have loss of articular cartilage at the hip joint. It's an increased risk in the elderly. Like I said, it's a thing of aging, and those with previous trauma to the hip joint. So if you have a fracture in the acetabulum, or you have a fracture of the head of the femur, or some kind of injury to either of those structures, that can predispose you to earlier onset arthritis. Presentation, these people they often have chronic hip and or groin pain. So often, keep in mind, it doesn't necessarily have to be in the hip. If someone has groin pain and it's been going on for a long period of time, that can often also be arthritis. And it's usually pain that increases with activity. So anytime you walk, you stand, you put weight on it, move it around, that can exacerbate the pain. Because remember, if I show you here the femoral head like this, and you have this cartilage like this, if it's worn away and it's just bone now, then it becomes where it's just bone on bone. Okay, and then bone on bone is just, it's two hard structures banging against each other. That causes all kinds of inflammation, and that's what ends up leading to the pain. So on physical exam, you're going to have decreased range of motion. Again, because this hip joint has totally lost its structures that, the cartilage that help reduce all the friction. So now it's tons of friction, bone on bone, and that's going to lead to, stiffness, inflammation, and that's what results in decreased range of motion for the hip. Usually these people, they complain of not only pain, but a very stiff hip, and then especially on internal rotation. So if you have the patient lay back and you passively try to internally rotate their hip, it's going to be very difficult to do it. It's going to feel like there's a lot of resistance. Even though they're not intentionally resisting, there's going to feel like a lot of resistance because of the arthritis. Diagnosis is by X-ray. That'll give you the diagnosis, and it shows joint space narrowing. So you'll see this distance between the femoral head and the acetabulum will be narrowed. You'll see sclerosis, subchondral cysts, and even osteophyte formation, which are just like bone spurs. These are all a result of these two hard surfaces banging against each other, and then the inflammation that results. So NSAIDs, NSAIDs are good because they'll decrease the inflammation, and those can provide some relief. Also corticosteroid injections, so you put a steroid in here, again, that decreases the inflammation. And then the best long-term outcome treatment is total hip arthroplasty, which is where basically you give the person a new hip. You come in and you cut the head of the femur off, and you put in a metal prosthesis, and you totally eliminate this arthritic process that's going on. Femoral neck fractures. So a femoral neck fracture would be, any kind of fracture through the neck like this. It could be like that or through that. And these are usually in high energy trauma in young adults, or they can occur in falls in elderly. So often you hear of, a sweet old lady falling and she breaks her hip. This is usually what they mean, is when they say an older person fell and broke their hip, it's usually they have a femoral neck fracture. The way these patients present is they have pain in the groin and or hip regions. So again, an important thing to know that hip pain can manifest, or hip problems can manifest as groin pain. And then they radiate along the medial thigh, so they travel down the thigh like this. Risk of osteonecrosis to the femoral head is a big thing here, because if you have a break here, or you have a break here and it breaks this medial circumflex femoral artery, or even the lateral circumflex femoral artery, that can cut off the major blood supplies to the femoral head. Diagnosis, you do an X-ray, you'll see the fracture, and then treat it with surgery. Osteonecrosis, also known as avascular necrosis or AVN. This, by definition, is ischemic necrosis of the bone. So you've cut off the blood supply, it's developed ischemia, and then the tissue starts to die. Hence the necrosis. And it's just like ischemia anywhere else in the body, like with a heart attack, a stroke. Presentation, it's acute onset of hip pain that is exacerbated by weight bearing. So they tell you have this hip pain, and then it gets worse when they go to put weight on it. Physical exam, there's going to be no signs of inflammation. So what are some signs of inflammation? Swelling, erythema, and temperature change. You're not going to see any of these, okay? What you're going to see is that they're going to have limited internal rotation and abduction. You can, as you notice here, internal rotation is a common problem with hip, is a common exam finding you're going to find with hip problems. We saw it with arthritis, same thing here, avascular necrosis, limited internal rotation, but also limited abduction. The labs are going to be totally normal as far as inflammatory markers. So the ESR, CRP, those are going to be normal. Typically, and with this, the boards loves to ask about this, is associated conditions. So they'll give you a presentation of someone with avascular necrosis, and then they'll ask you what's the most likely diagnosis, or they'll describe a person that has one of these conditions, and then they'll give their presentation of limited internal rotation or limited abduction of the hip, and then they'll ask you what's wrong, and so you have to deduce that they have this condition, and then it has put them at risk for avascular necrosis, and then that would be the answer for that particular question. So these associated conditions: femoral head fractures, so that's obvious, you're cutting off the blood supply. Sickle cell disease, and this is really due to so you have these sickle-celled blood cells, and they can get all jammed up within, just like anywhere else in the body where they would cause an occlusion or a thrombosis in a blood vessel or in an artery. Same thing here, it leads to thrombotic occlusion. So again, cutting off the blood supply, but in a different way. Prolonged steroid therapy, this usually weakens the bones. Prolonged steroid therapy, steroids stimulate osteoclast activity. So lupus as well, and this is thought to be due to vasculitis, so inflammation of actually the blood vessels again, so cutting off blood supply. Notice all these have to do with affecting the blood supply, and then also severe alcoholism as well. The way you diagnose this is that actually you would get an x-ray, but the x-ray is going to be totally normal. You're not going to see osteonecrosis. What you are going to see is that it's confirmed with an MRI. So the MRI will actually show you the osteonecrosis occurring in the femoral head. So how do you treat it? You can observe it, tell them to have limited activity, or you do surgery, which can include doing a total hip arthroplasty. So usually, you typically don't do a hip replacement in somebody who's less than 50 years old. This would be an example of where, and especially not in someone who's, less than like 35. This would be an example of where you would do a hip replacement in someone who's less than 35, because they've developed osteonecrosis, and then there's really no other viable treatment option. Septic hip, so this is an intra-articular infection. Intra-articular meaning within the joint itself, within the joint capsule, and it most commonly occurs actually in children, so it's a big pediatric problem, and it's a surgical emergency. Most common pathogen, boards will love to ask about this, is Staph aureus. Presentation: acute onset hip pain, so very severe hip pain, inability to bear weight. So the big thing you would ask is if this kid can bear any weight, and usually they'll tell you no weight at all, too much pain, and then also they have the signs of an infection, so fever. So on physical exam, you're going to see severe pain with passive range of motion. So you have the patient just sitting there, you manipulate their hip passively, that's going to cause a lot of pain. You'll see signs of inflammation, swelling, erythema, increased skin temperature. This is really important to pay attention to because you can actually see this in a question stem and it can give you the answer, is that the hip rests in a position of flexion, abduction, and external rotation, and this position produces the maximum hip capsular volume. And by doing that, it helps essentially pull the hip out this way, and then reduces any kind of friction or contact, and thus reduces the pain that the patient would experience as a result of this. So it's a relief mechanism. Diagnosis: so you're going to do an x-ray, ultrasound will show it to you. You're going to look for the white count. You're going to see elevated inflammatory markers. The way you confirm this is you stick a needle in there and you aspirate the hip joint fluid, the synovial fluid, and then you send the aspirate for a gram stain, culture, and white blood cell count. If it grows bacteria on the stain or then the culture, and then you see an elevated white count, very good indication that it's a septic hip. The way you treat it is you give antibiotics. Sometimes antibiotics can do the job alone, and or you would do surgical irrigation debridement, or IND, where you'd actually go in there and clear out the bacteria and clear out any infected structures. So a couple of pediatric hip disorders we'll cover here. So Legg-Calve-Perth Disease. This is basically a pediatric AVN. So what happens here is you have impaired blood flow to the head of the femur, resulting in ischemia and then eventually osteonecrosis that halts the bone growth. So that's the big problem with kids, is that they're still growing, so this would halt the bone growth. Common in patients, boys age 3 to 10. This is an important thing to pay attention to because this can help you narrow it down to Legg-Calve-Perth. Presentation: they could have hip, thigh or knee pain. So hip problems can manifest as knee pain, just like knee problems can actually manifest as hip pain. Another thing to take note of, a side note, is that spine problems can actually manifest as hip pain as well, and actually hip problems can manifest as back pain. So all important things to know. Limping, so obviously because their hip is deformed, and then antalgic gait. Physical exam, you're going to see decreased range of motion in the affected hip, especially internal rotation and abduction. Diagnosis, you're going to do an x-ray. This is a good x-ray to commit to memory. So what you can see here is the black arrow. This is where it's affected. You notice with the white arrow, this is the normal side. This is the LCP, Legg-Calve-Perth Disease side. So you can see it's the femoral head is nice and healthy here. It's resting in the normal position here. This side, it's smaller. You can already see kind of some breakdown here in the femoral head. So how do you treat this? You can do traction and then do reduced weight bearing, and then eventually do surgery. So the other pediatric disorder we're going to talk about is slipped capital femoral epiphysis. So what this is a fracture through the growth plate of the proximal femur, causing the top of the femoral head, also known as the epiphysis, to slip along the growth plate. So what you have here is, you can see, so here's the epiphysis indicated in E, and then as you can see, the growth plate here has widened, and it's actually caused the top to slide on top of the base of the growth plate here. So you actually see the top of the femoral head here sliding on this growth plate. And the reason for that is you wouldn't see this in an adult because the growth plate is already fused, but in a kid, this is a very mobile area, and so this can happen, especially if there's a fracture. It's common in adolescent boys, especially if they're obese, and then often associated disorders they're associated with endocrine disorders such as thyroid or pituitary problems. Presentation, they can have hip, groin, or knee pain, limping, antalgic gait. Physical exam, you're going to see decreased range of motion, especially with internal rotation and abduction. The hip externally rotates when flexed. So you notice one way to differentiate this from Legg-Calve-Perth disease is that the common patient population, the age, also these boys tend to be more obese, and then also often associated with endocrine disorders. Those are two things that can help. The other thing here is obviously the diagnosis is by x-ray, is looking at the x-ray. So if you'll notice, this x-ray, you notice that it's slipping on the growth plate like that. That's what you're going to look for. Versus in Legg-Calve-Perth, you're going to look for destruction here of the femoral head. Treatment is percutaneous pinning of the femoral head. So what would happen is the orthopedic surgeon would stick a pin in surgically like this. And what this does is it fixes this femoral head so it doesn't continue to slip on the growth plate here and maintain it in place. And that closes out our discussion of the clinical pearls for the hip joint, and it closes out our entire discussion of the hip joint as well.